Hi everyone, this is Doc Ina and this is my lecture on preterm labor. To download my lecture deck in PDF form, please go to my WordPress site, Docina Obigaine. This is the reference for my lecture. It's Williams Obstetrics, Chapter 42, Preterm Labor. And this is the outline for my lecture. So first, let's define some terms that we will use in this lecture. So for preterm labor, that is labor that commences less than 37 weeks age of gestation. We have early preterm, which is labor that commences less than 33 and 6/7 weeks. And for the late preterm, that's labor that commences at 34 to 36 weeks AOG. Low birth weight infants are infants that are born less than 2,500 grams. Very low birth weight infants are infants that are born weighing less than 1,500 grams, and extremely low birth weight infants are infants that were born at less than 1,000 grams in weight. PPROM, or preterm premature rupture of membranes, is the spontaneous rupture of the fetal membranes before 37 completed weeks and before the labor onset. So what are the causes of preterm labor or preterm delivery? There are four main direct reasons for preterm births, and these are spontaneous unexplained preterm labor with intact membranes, idiopathic preterm premature rupture of membranes or PPROM, delivery for maternal or fetal indications such as hypertension, or probably there's placental abruptio or placenta previa or any other fetal complications, and of course, multifetal gestations. Uterine distension is one of the most common causes or risk factors for preterm labor or preterm delivery. And most common examples for this would be multifetal pregnancy and hydramnios. It is postulated that early uterine distension acts to initiate expression of contraction-associated proteins or CAPs in the myometrium, and there's also increase in the gastrin-releasing peptides or GRPs with uterine distension that promotes myometrial contractility. And also, the excessive uterine distension leads to early activation of the placental fetal endocrine cascade. Stress can also be a risk factor for preterm labor, and the premature rise in cortisol and estrogen results in an earlier loss of uterine quiescence. The spontaneous preterm labor is associated with an early rise in maternal CRH levels, and we know that CRH levels are associated with stress, and that CRH determination may be a useful biomarker for preterm birth risk assessment. Infection, of course, is one of the causes of preterm labor, and microbial invasion of the reproductive tract is sufficient to induce infection-mediated preterm birth. More specifically, there is ongoing subclinical infection. Bacteria can gain access to intrauterine tissues through, number one, transplacental transfer of maternal systemic infection. Second is through a retrograde flow of infection into the peritoneal cavity via the fallopian tubes, and ascending infection of the bacteria from the vagina and the cervix. Usually, the commonly implicated microorganisms are Gardnerella vaginalis, Fusobacterium, Mycoplasma hominis, and Ureaplasma urolithicum. The lower pole of the fetal membrane decidual junction is contiguous with the cervical canal orifice, which is patent to the vagina. And this anatomical arrangement provides a passageway for microorganisms, and ascending infection is considered to be the most common. Ascending microorganisms colonize the cervix, the decidua, and possibly the membranes, where they then enter the amniotic sac, and the lipopolysaccharide or the LPS or other toxins elaborated by bacteria induce immune cell recruitment into the reproductive tract and cytokine production by immune cells and by cells within the cervix decidua, membranes, or fetus itself. Both the LPS and cytokines then provoke prostaglandin release from the membranes, decidua, or cervix, and this influences both cervical ripening and loss of myometrial quiescence. Cigarette smoking, inadequate maternal weight gain, and illicit drug use, these are all lifestyle factors that have important roles in both the incidence and outcome of low birth weight neonates as a consequence of a preterm delivery. Overweight and obese mothers have an elevated risk of preterm birth, and other maternal factors that are implicated include young or advanced maternal age, poverty, short stature, and vitamin C deficiency. Also implicated as risk factors are genetic factors, short intervals between pregnancies, such as an interval of less than 18 months, and of course, a prior preterm delivery. These are the complications that we might encounter for infants who are born prematurely. And in this table, we see here the short-term problems and the long-term problems seen in very low birth weight infants. And most commonly, we note the presence of respiratory distress syndrome in this very low birth weight infants. We also note hyperbilirubinemia, necrotizing enterocolitis, the increased incidence of hospital-acquired infections, perinatal infections, intraventricular hemorrhage, periventricular leukomalacia, retinopathy of prematurity, water and electrolyte imbalance, and acid-base disturbances, among others. For the long-term problems, we have bronchopulmonary dysplasia, reactive airway disease, asthma, failure to thrive, short bowel syndrome, cholestasis, and cerebral palsy, of course, and possible hydrocephalus, cerebral atrophy, blindness secondary to the retinopathy of prematurity, retinal detachment, myopia, strabismus, and so on and so forth. So, how do we diagnose preterm labor? Preterm labor is primarily diagnosed by symptoms and physical examination. So, usually the patient comes to us complaining of a painful or sometimes painless uterine contractions. They also complain of pelvic pressure, menstrual like cramps, watery vaginal discharge, and lower back pain. Sonography is used to identify asymptomatic cervical dilatation and effacement. And we note on physical exam or internal examination cervical changes such as changes in the dilatation or effacement. We can also diagnose preterm labor using an ambulatory uterine monitoring device. So this is an external tocodynamometer belted around the abdomen and connected to an electronic waist recorder, which allows a woman to ambulate while uterine activity is recorded. Results are transmitted via telephone daily. Women are educated concerning signs and symptoms of preterm labor, and clinicians are kept apprised of their progress. We can also use fetal fibronectin. And fetal fibronectin is a glycoprotein that is produced in 20 different molecular forms by various cell types, including hepatocytes, fibroblasts, endothelial cells, and fetal amnion. Now, present in high concentrations in maternal blood and in amniotic fluid, it is thought to function in intercellular adhesion during implantation and in maintenance of placental adherence to uterine decidua. Fetal fibronectin is detected in cervicovaginal secretions in women who have normal pregnancies with intact membranes at term. It appears to reflect stromal remodeling of the cervix before labor. Now, some experts reported that fibronectin detection in cervicovaginal secretions before membrane rupture is a possible marker for impending preterm labor. Fetal fibronectin is measured using an enzyme-linked immunosorbent assay, and values exceeding 50 nanograms per ml are considered positive. So how can we prevent preterm birth or preterm delivery? Now, one of the ways we prevent it is by doing a cervical cerclage, which is also known as a cervical stitch. And this is a treatment for cervical incompetence or insufficiency when the cervix starts to shorten and open too early during a pregnancy, causing either a late miscarriage or preterm birth. Usually, the treatment is done in the first or second trimester of pregnancy, usually in the second trimester or early second trimester, for a woman who has had one or more late miscarriages in the past. Now, the word cerclage means hoop in French, as in the metal hoop that encircles a barrel. The treatment consists of a strong suture sewn into the or around the cervix early in the pregnancy, usually between weeks 12 to 14. Some prefer to do it at weeks between weeks 14 to 18, and then we remove this towards the end of the pregnancy when the greatest risk of miscarriage has passed. The procedure is performed under local anesthesia, usually by way of a spinal block. It is typically performed in an outpatient basis by the obstetrician gynecologist, of course. Now, what are some of the types of cervical cerclage that we can perform? One is a prophylactic cerclage to be used in women who have history of recurrent mid-trimester losses and who are diagnosed with cervical insufficiency. We can also do a prophylactic cerclage for women identified during sonographic examination to have a short cervix. And we can also do a rescue cerclage, which is done on an emergency basis or done emergently when cervical incompetence is recognized in women with threatened preterm labor. Now, another way of possibly preventing a preterm birth or a preterm delivery is by giving prophylactic treatment using progestin compounds, and this involves administration of progestins or progesterone to maintain uterine quiescence. And the basis of this is, of course, human parturition involves functional progesterone withdrawal mediated by decreased progesterone activity of progesterone receptors. Now, progesterone levels in most mammals, or of course in humans, fall rapidly before the onset of labor, and this is termed progesterone withdrawal. And this is considered to be a parturition triggering event. During human parturition, however, maternal, fetal, and amniotic fluid progesterone levels remain elevated with no decline. It has been proposed that human parturition involves functional progesterone withdrawal mediated by decreased progesterone activity of progesterone receptors. It follows conceptually that the administration of progesterone to maintain uterine quiescence, of course, may block preterm labor, and this hypothesis has stimulated several studies in the past decades or so. Now, how do we diagnose PPROM or pre-labor premature rupture of membranes? Of course, we do this by history. Okay, so we note a history of vaginal leakage of fluid, either as a continuous stream or as a gush of fluid. And of course, this history of vaginal leakage should prompt us to do a speculum examination to visualize gross vaginal pooling of amniotic fluid. We can confirm also the ruptured membranes by doing either a sonographic examination or an ultrasound to assess amniotic fluid volume, or we can also do pH testing of cervicovaginal fluid, and we will see that there's a slightly alkaline reaction in the litmus paper. Of course, we know that amniotic fluid has a pH of 7.1 to 7.3. Now, how do we manage patients with PPROM? Of course, most clinicians will opt to hospitalize these patients. Okay, so concerns regarding the cost of lengthy hospitalizations are usually moot because most women with ruptured membranes enter labor within a week anyway, and they deliver within a week. Now, we have to be wary, of course, of the increased incidence of cord prolapse among these patients. Now, the next step is to give, of course, steroids, to administer steroids in these patients. Now, the National Institutes of Health, or the NIH, in their Consensus Development Conference, recommended a single course of antenatal corticosteroids for women with preterm membrane rupture before 32 weeks and in whom there was no evidence of chorioamnionitis or intraamniotic infection. Now, the ACOG, or the American College of Obstetricians and Gynecologists, recommend single-dose therapy or a single-dose administration of corticosteroids from age of gestation 24 to 32 weeks. There's no consensus regarding treatment between 32 and 34 weeks, and corticosteroid therapy is not recommended before 24 weeks. Now, we can give either betamethasone or dexamethasone. Now, for the dose of betamethasone, we can give it at 12 milligrams IM for 2 doses every 24 hours. And then for dexamethasone, the dose is 6 milligrams IM every 12 hours for 4 doses. Now, the issue here would be whether to do intentional delivery versus expectant management. Now, some clinicians, of course, will prefer expectant management and some will prefer intentional delivery. Of course, with intentional delivery, we reduce the length of maternal hospitalization and also reduce infection rates for both the mother and the neonate. The downside to intentional delivery, of course, is that there's higher incidence of neonatal death secondary to pulmonary hypoplasia and sometimes sepsis. Thus, neither management approach proved to be superior for perinatal outcomes. Now, in the end, I guess it will be the prerogative of the obstetrician gynecologist whether to do intentional delivery versus expectant management. But usually, we base the choice mainly on the clinical scenario, and of course, we also base it on the age of gestation of the fetus or the patient. And very important also in the management of PPROM is to minimize digital or internal examination. Of course, that is to avoid intraamniotic infection. Now, part of the management of PPROM is, of course, to administer antimicrobial therapy. And the benefits of this is, of course, there's a decreased incidence of chorioamnionitis and decreased incidence of fetal or newborn sepsis, and sometimes the pregnancy is more often than not can be prolonged to approximately 7 days or probably less. We can give ampicillin or erythromycin, and we have to avoid coamoxiclav because this drug um, is associated with increased incidence of necrotizing enterocolitis. Now, this is a very nice table showing to us a summary of the recommended management of preterm ruptured membranes. Now, note here that for 34 weeks AOG or more, we proceed to delivery. Okay, usually by induction of labor, and we give or administer Group B strep prophylaxis. For 32 weeks to 33 weeks AOG, the recommendation is expectant management unless fetal pulmonary maturity is already documented. Group B strep prophylaxis is also recommended. Now, for corticosteroids, there's no consensus, as I've already mentioned, but some experts recommend giving corticosteroids at 32 to 33 weeks. Antimicrobials should be given to prolong latency if, of course, there's no contraindications. Now, for 24 to 31 weeks AOG, again, expected management is recommended. We give Group B strep prophylaxis. We give a single course corticosteroid. Well, tocolytics, there's no consensus in giving tocolytics. We give antimicrobials to prolong the latency if there's no contraindication. Now, if the patient is less than 24 weeks AOG, of course, this is a poor prognosis. So we counsel the patient regarding this, and expected management or induction of labor can be done depending on the case or the clinical scenario. Group B strep is not recommended. Corticosteroids, of course, is not recommended before 24 weeks, and antimicrobials is recommended also. And there are incomplete, although there are incomplete data on the use of this in prolonging latency. Now, as I've mentioned a while back, one of the risks of PPROM is intraamniotic infection or clinical chorioamnionitis. If chorioamnionitis is diagnosed, then prompt efforts to effect delivery, preferably, of course, through the vaginal route, are initiated. There's higher incidence of sepsis with chorioamnionitis, and of course, there's also higher incidence of respiratory distress syndrome, early onset seizures, intraventricular hemorrhage, and periventricular leukomalacia in the newborn. And what are the signs of intraamniotic infection? Fever is the most reliable indicator with a temperature of 38 degrees centigrade or higher. Other signs include maternal leukocytosis, sustained maternal or fetal tachycardia, uterine tenderness, or a malodorous vaginal discharge. So, how about the management of preterm labor with intact membranes? If possible, delivery before 34 weeks is delayed, or if we can possibly prevent delivery, then we institute or administer steps in order to delay the delivery if the pregnancy is less than 34 weeks AOG. Now, the American College of Obstetricians and Gynecologists recommend a single rescue course of antenatal corticosteroids for women um, before 34 weeks whose prior course was administered at least 7 days previously. Now, for antimicrobial treatment of women with preterm labor for the sole purpose of preventing delivery is generally not recommended. But of course, if you see signs of infection that may be the causative factor for the preterm labor, then by all means, you can give antimicrobial treatment. Now, as for bed rest, there's really no hard evidence regarding the benefits of bed rest, but again, most clinicians would recommend, of course, bed rest. The use of cervical pessary, again, no evidence. And cerclage may possibly be useful in delaying delivery. Now, how about tocolysis to treat preterm labor? The ACOG has actually concluded that tocolytic agents do not markedly prolong gestation. However, the use of tocolytic agents may delay delivery in some women for up to 48 hours. And this delay in delivery, up to 48 hours, is crucial because this buys us some time to allow transport of our patient to a regional obstetrical center that is or that has facilities to take care of a preterm newborn. And of course, permit time for corticosteroid therapy. And some of these tocolytic agents include beta adrenergic agonists, calcium channel blockers, or indomethacin. And these are the recommended tocolytic agents for such short-term use up to 48 hours. Now, in general, if tocolytics are given, they should be administered concomitantly with corticosteroids. Now, let's discuss some of these tocolytic agents one by one. So, let's discuss first the beta adrenergic receptor agonist. Several compounds react with beta adrenergic receptors to reduce intracellular ionized calcium levels and prevent activation of myometrial contractile proteins. In the United States, ritodrine and terbutaline have been used in obstetrics, but only ritodrine has been approved for preterm labor by the FDA. Now, the beta adrenergic receptor agonist may provide a brief delay in delivery, approximately 48 hours, which can aid, of course, maternal transfer to tertiary care or permit fetal lung maturation with corticosteroids. However, the possible maternal side effects of beta adrenergic receptor agonists are pulmonary edema, acute respiratory distress, volume overload, increased capillary permeability, cardiac rhythm disturbances, and myocardial ischemia. Another tocolytic agent that we can use is magnesium sulfate. Ionic magnesium in a sufficiently high concentration can alter myometrial contractility. Its role is presumably that of a calcium antagonist, and when given in pharmacologic doses, it may inhibit labor. The intravenous magnesium sulfate in a regimen of 4 grams loading dose followed by a continuous infusion of 2 grams per hour usually arrests labor. Now, the FDA warned against prolonged use of magnesium sulfate given to arrest preterm labor due to bone thinning and fractures seen in fetuses exposed for more than 5 to 7 days, and this is attributed to the low calcium levels in the fetus secondary to the calcium antagonist activity of magnesium sulfate. Magnesium sulfate also confers a neuroprotective effect for the fetus who are preterm, and very low birth weight neonates whose mothers were treated with magnesium sulfate for preterm labor or preeclampsia were found to have a reduced incidence of cerebral palsy at 3 years. Another tocolytic agent which we can use are the prostaglandin inhibitors. Prostaglandins are intimately involved in contractions of normal labor, and we know that from our physiology, right? So, antagonists act by inhibiting prostaglandin synthesis or by blocking their action on target organs. A group of enzymes collectively termed prostaglandin synthase is responsible for the conversion of free arachidonic acid to prostaglandins, and several drugs block the system, including acetylsalicylate and indomethacin. Indomethacin, as a prostaglandin inhibitor, is administered orally or rectally at a dose of 50 to 100 milligrams, followed at 8-hour intervals not to exceed a total of 24-hour dose of 200 milligrams. Indomethacin use is limited to 24 to 48 hours because of concerns for oligohydramnios. However, this oligohydramnios is reversible with drug discontinuation. Another tocolytic agent which we can use is the calcium channel blocker. Calcium channel blockers act to inhibit by various mechanisms calcium entry through cell membrane channels. The example of this would be nifedipine. However, warning though, the combination of nifedipine with magnesium used for tocolysis is potentially dangerous. Nifedipine enhances the neuromuscular blocking effects of magnesium that can interfere with pulmonary and cardiac function. So never use nifedipine as a tocolytic agent when you're already using magnesium sulfate as a tocolytic agent. And lastly, we have atosiban and nitric oxide donors. So atosiban, this is a nonapeptide oxytocin analog and is a competitive antagonist of oxytocin-induced contractions. And for nitric oxide donors, these potent smooth muscle relaxants affect the vasculature, the gut, and the uterus. And just a warning though, because maternal hypotension is a common side effect of nitric oxide donors. So, as a summary, we've defined preterm labor and some of the associated terms with preterm labor, such as PPROM and low birth weight infants. We also discussed the causes, risk factors, or contributing factors for preterm labor and delivery, how to diagnose preterm labor, the prevention of preterm labor or delivery, management of PPROM, and management of preterm labor with intact membranes, and finally, we also discussed some of the tocolytic agents. That's it for my lecture. Thank you for watching, and please don't forget to subscribe in my YouTube channel, Ina Irabon, and my WordPress site, Doc Ina Bigayne. Thank you.